must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support. And now for the show. Hey, everybody, and thanks for listening to the Healthcare Education Transformation Podcast. My name is Brandon Hohen, and I am joined by my fellow co-host, Stephanie Weirach. Unfortunately, F. Scott Field was unable to join us today due to other reasons, but today we have the esteemed pleasure of welcoming a very special guest on the show today from across the pond to talk about evidence-based clinical practice and how we can really start to improve physio education. As today we welcome the one and only Adam Meakins. Now, for those of you who have not heard of him, Adam is a specialist sports physiotherapist and extended scope practitioner with an interest in the management of the shoulder and upper limb. He works both in the NHS and the private sector at sites and locations around Hertfordshire, if I pronounced that right at all, which I probably didn't. Adam, thank you so much for your dedication to the PT profession and for taking the time to come on the show today to talk with us and our listeners. Do you think you could tell our listeners a little bit of extra background into kind of who you are and your journey to where it's led to where you are today?
Sure. So first things first, thanks for inviting me on, Brandon and Stephanie. It's good to speak to you eventually, at last. And you did pronounce that wrong, Brandon. That's Hertfordshire.
Perfect. Writing it down.
To say the difference in language, although we share a common language of pronunciations, I still get all your names mixed up as well, so don't worry about it. Okay, we'll go back into your original question, mate. So my background is a little bit diverse. So physiotherapy is my third career. So I started off my life when I left school many years ago now, over 25 years ago. My first career as a young man was in the British military, so I spent a few years in the army. Learning a lot about myself and about other people, which I found very useful going forward in life. And then after I left the army, through various different reasons, I found myself working as a personal trainer for a couple of years. But I soon got bored of that, and I wanted to learn a bit more about the human body and how to help people get stronger and more robust. So I went and did a first degree in sports science back in the mid-90s. And got a diploma in strength and conditioning coaching from that. And so I started to trade myself as a strength and conditioning coach for myself, working independently, but also worked for a couple of amateur sports clubs, rugby and football over in the UK being the main ones. And it was whilst working as a sports coach that strength and conditioning coach, I started to sort of see physiotherapists, interact with physiotherapists. I started to have clients of my own that started to break down and get injured. And that sort of led me into the interest into the human body as to why sometimes it broke down and what was going on there. So I thought, I'm going to try and learn a little bit more about that. And that's what led me into my interest into physiotherapy. So in 2000, I managed to blag my way onto an undergraduate program at the University of Hertfordshire. And I'll be honest and open with you, I found it quite, what's the word I'm looking for? Not what I was expecting. I became very disillusioned with the training that I was getting as a physiotherapist or as a graduate physiotherapist. And I managed to, although a few issues along the way, finally graduate in 2003 as a physio. And then as a junior physio in the UK, we do our NHS rotations. I started off my career working in the NHS. And again, found that quite a challenge. I had a different sort of population group that I had to work with now. So I was used to working obviously with fit, motivated younger populations. And now I had the elderly population, a not so motivated population, working in various different hospitals, etc. So I soon started to specialise into the musculoskeletal. That's where my interest was. So I then went into private practice in musculoskeletal management, physiotherapy, and in private practice again found various different challenges working there. And then that's when I started to specialise in the upper limb, probably about 10 years ago now. So working for about 5 years as a physio, I started to sort of focus my attention onto upper limb conditions, more through, again, personal interest as well. And through various different things as well over the years. I've worked in professional sport. I still do occasionally consult with elite level athletes working in upper limb conditions with problems. But the main sort of role that I have now is pretty much split, as you mentioned, between this NHS role, this extended scope practitioner role, which is basically a triaging role that physiotherapists are now finding themselves into, working as a first contact practitioner, assessing, triaging, deciding what's the best care management plan for people with upper limb conditions. And then sort of the other 50% of my time I work in private practice as a standard sports physio, where I can get my hands dirty at the coalface, so to speak.
I think it's really interesting, Adam, how you have that background as a personal trainer. So I'm interested in this next question. I'm wondering if you could walk us through how your clinical beliefs about pain and structure, biomechanics, exercise, how they've evolved from when you came out of school to where you are now as an expert in the shoulder and upper limb, and as somebody who works in both private practice as well.
Yeah, great question. The first thing to say is they've evolved hugely. If you look back probably even just a year or two ago, my thoughts and my thinking processes have changed as I understand more and I learn more around why things hurt and why things break down. So yeah, they've changed dramatically. Going right back to my very first sort of degree as a sports scientist, learning the biomechanics. It was very heavy on biomechanics. It was pretty much predominantly all that was. And then in my early physiotherapy training, again, the biopsychosocial model was taught in 2000. It was mentioned briefly, but still I would say that the majority of the training I got was still very biomedical. I still remember lectures on pain, talking about pain sensors and pain fibers and how nociception, was the cause of pain a lot of the time, where these other factors were discussed briefly as having an influence. But it was very much, a bottom-up model. That's what I was taught. There is structural defects and problems that are contributing to people's pain and problems. And you as a physiotherapist need to go and find out what they are and address and fix them. So although there was some mention of these other factors, it wasn't given, credence. It wasn't the main point. And so, I came out as a physiotherapist that I think still happening today, although probably quite not the same amount or level, but a lot of physiotherapists are taught to go and find problems in patients and then try to fix them. And it is looking for the biomechanical faults and issues that I find myself now over the years has started to realise, well, actually, it's probably not that simple. I think I've got to the position now over the years where the only certainty I have is in my uncertainty as to why things hurt. And I think that is something that is very hard to teach and educate in the early stages. And I think it is a huge barrier to try and to get across to clinicians, and not just physiotherapists. I think all healthcare clinicians trying to educate people that actually it's not simple as, a rotator cuff tear. It's not just as simple as some arthritis in a joint as to why somebody has pain and disability. It's just taking that sort of more global, holistic view of the person in general and weighing up the contributing factors as to what is contributing to this person's experience or perception of pain. And that is something to say that is very challenging. So I think it takes a while. It takes years probably to get that confidence in uncertainty and getting that feeling of comfort when you're feeling uncomfortable about why something hurts and how you're going to try and address that. And there's something thing that I think can be taught a little bit better, but I do think experience plays a key factor in that.
Yeah, I think, Adam, that your points that you make up, I think we've definitely seen some crossover and carryover here over in the US. There's definitely a very big emphasis on the biomechanical component as well. And you're right, patients with pain, it's not that simple. Sometimes it can be simple as that, but many times it's a lot of other things combined. Like there's so many factors between psychosocial, biomechanical, other things contributing. And you're kind of like, how much of each one is contributing to this person's problem, and what's the biggest one right now that I should intervene with? And
absolutely.
And it's hard because you're right. Especially with our schools, at least, I'm not sure specifically all details how it is in the UK. I know we talked to Roger Carey in the past to get a brief overview, but at least in the US, there's an accrediting board, and then a lot of schools have to end up teaching to the licensure test to a degree, because at the end of the day, kids have to pass it. Now, whether that's the right thing, I'm not the expert on that at all. But I think it was really, I will agree that I kind of felt rather frustrated when I came out, because learning and experiencing people and like, there's way more to it than just this. Like biomechanics are not everything. And I feel, it's hard to address that, but I feel like we have to do something. So I don't know whether that's a DPT thing, whether that's a residency thing. I mean, I don't know. That's the big issue I got with that.
Yeah, it's a complex area, and again, it's just treading that fine line. It's finding the balance between all these factors and being able to associate, an adequate time to each one. So if you're doing a program of training and education, I just think there needs to be equal balance given, and I think it's not. It's not, the biomechanics, again, this is where sometimes when we're explaining biopsychosocial approach, people think that we're excluding the biomechanics. They think that we're negating the fact that they do have a role in some pains and some problems, and that's very hard to try and get across, that we're not saying that at all. We are trying to promote that biomechanics, as you said, do have a role to play, and they do need to be assessed, and they do need to be addressed sometimes. But we just also need to give equal weight to the other factors, the psychosocial factors as well, as also contributing. And I think at the moment, a lot of the education systems, that weighting, that equal weighting across all three areas just isn't there. A lot of it is still heavily focused on the biomechanics.
No, I agree. And especially, the phrase, don't let the pendulum swing too far in one direction, seems to hold very true in this. So, Adam, with you being in the UK, just to gain some perspective for our listeners, perhaps here in the States, do you see any differences between physiotherapy in the UK versus the US?
Yes and no. I think I see that physiotherapy has a global issue wherever you are. So I think I see it in the US, the UK, and Scandinavia, and all the places now that I've been fortunate enough to travel to, being invited to rant and rave to various different people in various different locations about my views on physiotherapy. And whenever I discuss with physios, during the coffee breaks and the lunch breaks, I hear them explaining the same frustrations that they have as a physiotherapist that I have across, and it is global. So, we all have these problems that we have when we're dealing with people with pain. So I think those sort of global issues are there. So again, human beings tend to be fairly similar no matter where you are in the world. Obviously, it's again, the psychosocial factors and the cultural factors are slightly different. But at the end of the day, when you're a physiotherapy, I see as a physiotherapist a lot of challenges and difficulties in trying to educate patients around pain, again, trying to get across that uncertainty. Well, it's not as simple as the reason why you've got shoulder pain. It's not just down to that rotator cuff tear. It's not that simple. It's not that easy. And I find that's a global problem in how we try to educate and explain that. And again, I see the same issues again with physiotherapists trying their best to encourage more movement, trying to get everybody, more active. That isn't easy. That's something that's very hard to do as well. So I think it's something that we just got to be recognizing, that our role, I think now as physios, is trying to promote people to become more active and to move more, regardless of whether they've got pain or not. And I think that is a global challenge that we face as a profession. But then I think I do see some huge issues with regards to the, I suppose the difference I see with regards to the financial reimbursement schemes that are happening across the world. So I see the US system very much completely different from the UK system. So I see, the problem with the US system, from my eyes and perspective, and correct me if I'm wrong, is the financial reimbursement as to how you get paid as a physiotherapist is based on what you do to a patient. And I think that's completely the wrong way to do it. In the UK, we're a little bit more fortunate because we get paid for our consultation time rather than what we do or don't do with somebody. And I think that's something that I prefer to work underneath that model of healthcare. I prefer to be able to be reimbursed for my consultation time, not what I actually do or don't do to a patient, because I find that can drive poor practice in both ways. So I find, again, if you are being reimbursed for doing things to people, what's the chances are that you're probably going to be doing more things to get more reimbursement? And that can lead to over-diagnosis and over-treatment. But then I also see a downside to it as well, because I also see, people that are just coasting and lazy because they are knowing that they're getting a set fee for just seeing people. So they do the bare minimum in their sort of reimbursement allotted slot. And so that's where sometimes you can see the lazy coasters. So I think, again, there's a positive aspect and a negative aspect to that sort of financial reimbursement scheme.
Yeah, I think it's definitely a fine balance. The overutilization aspect, as far as what you're saying, is paid as a consultant, underutilizing therapy. I'm not sure if there's a perfect healthcare system that has been able to balance that out and make that perfect payment model. But I definitely think that the consultation model is an interesting one. And I'm not sure if we'll ever move to that, but in the United States, healthcare is moving towards more value-based care based on outcomes. So perhaps that's something that we'll eventually move into. I'm interested, Adam, with you teaching on the shoulder and talking a little bit about how, you came out of school, you had this focus on biomechanics. Brandon agreed that, he thought that his focus was more on biomechanics versus looking at the biopsychosocial aspects and other factors that may go into helping a patient recover from an injury. But when you're teaching the shoulder, what are the most important things that you think a clinician should assess and consider when treating a person with shoulder pain or disability based on the best available evidence?
Well, first and foremost, I think the main thing to always keep at any healthcare practitioner's forefront of their mind is this problem due to a musculoskeletal issue? So not something else, especially something that could be sinister or harmful. So things such as cancers, TBs, osteonecrosis, etc. So I think that's a key priority first. That's the sort of the thing to always have at the forefront of any clinician's mind is this condition something else masquerading? Is this something that could then, ultimately cause this person a lot of harm or even, worst case scenario, death? Now, that is something that can be easier said than done because spotting sinister pathology in the early stages can be very, very tricky. I mean, we often use red flag screening questionnaires and questions in our history, but these have often, again, in the research, been shown to be inadequate and having poor sensitivity. And a lot of these red flag signs don't actually manifest themselves until later on with some sinister pathologies. So for me, I think the key point here is for clinicians to always remain vigilant. That's the word I'm looking for, Adam. So again, making sure that clinicians are aware of these factors that are out there, the incidence and the prevalence, which again, if we're being honest, are low, but they are still out there. So making sure that they don't switch off their sort of detectors, their sort of suspicion, sort of warning signs. They keep an eye out for these signs. Because again, you read the research and you see the case studies that are coming out with physios that have just delayed patients going for onward referral or getting things checked out and just stubbornly carrying on treating something that may have started off with all the signs and symptoms of something ambiguous and musculoskeletally orientated, but then very much starts to deteriorate and starts to show some signs of not progressing the way it should do and actually starts to present later on as something else. But because they've switched off their sort of critical thinking, they're not keeping an eye out for things, they just keep treating and delay this patient from going to get what they need. So I think that is the key factor for me, is that when I am trying to promote how to manage shoulder pain and shoulder problems, just getting patients to recognize, first and foremost, is this actually a musculoskeletal condition and not something else?
I think that's a really good point because I think actually it's interesting. The other day I've been seeing a patient for the past few weeks with lumbar radiculopathy, or so I thought, didn't have any red flags in the history. And then she was doing really well. And then kind of in the last couple of weeks, for whatever reason, and there's no change in anything else, she's just started to decline and there's some neuroscience. So it's like, all right, you got to get in. You got to go get checked.
Yeah. And that's just that keeping that sort of, vigilance around you. It's just making sure that you don't just after you've done your initial evaluation and you've taken that basic history, then you think, right, there's nothing there in that initial consult that gives me any concern. And then you just start to carry on a course of treatment, but you're not actually going back and readdressing that evaluation and seeing how things are changing. And I think, to say, sometimes physiotherapists are a bit guilty of that. They switch off sometimes once they've cleared these sinister signs. So there's nothing there that's going to cause me any concern. And then they just don't keep an eye out for it as things start to progress, as they carry on seeing the patient. And I think the other thing is, again, is to consider that, physios need to do is, again, like we talked about, is just keep a global eye on the sort of the psychosocial factors as well that could also be affecting a physiotherapy's outcome, success or failure. So, just keeping an eye out on the conditions that a patient may bring with them to consult, such as anxiety, stress, depression, but also their social factors. And I think physios don't recognise this enough. But again, the research is telling us to keep an eye out for patients coming from, a lower education level, different socioeconomical backgrounds as well, because all these other factors will govern, outcome success with patients that we're seeing as physiotherapists. And they all have an impact, and say it all affects how we manage, assess and treat these patients from these different variable factors. And then the last bit to keep an eye out for, I think, is the patient's beliefs and expectations of physiotherapy, because again, that's something now that's becoming more prevalent in the research, is that trying to gauge a patient's expectation and their belief of whether they think physiotherapy is going to be successful or not for them is a very strong predictor as to whether physiotherapy is going to be successful or not for them. So I think, again, in our evaluations and our histories, there's a couple of key questions now that I go around promoting to clinicians to say, ask your patient, what do you expect? What do you think is going to happen from a course of treatment through physiotherapy with me today? Do you think it's going to be successful or not? Just find out where that patient's beliefs are, where their expectations are, because it is going to have quite a large impact onto their prognosis.
Absolutely. And I think the study that really stuck out to me was the one, I forgot who wrote it, but it was the one with the rotator cuff tears, and how expectations was like the number one predictor of failure for conservative care. I was like, wow, that's pretty astonishing.
I think that was Rachel Chester in 2016. I think in BGSM was one of, I don't know if it was rotator cuff tears, but I think it was subacromial shoulder pain. And they looked at a lot of different, factors, speedy scores, chronicity of shoulder pain, levels of shoulder pain, night pain, range of movement, etc. But they also looked at patients' beliefs and expectations of what they thought was the best treatment for them, physiotherapy or surgical management. And pretty much, it wasn't the speedy scores, wasn't the chronicity, wasn't the severity or irritability of their pain that predicted their success or not with physio. It was their expectation. It was a really, really strong predictor.
Well, and I think that that's something that's important to let the patient know about, when they come to see you. I if I could count the number of times that a patient's been like, well, I'm not sure if this is going to work, but I think it is, I'd be a millionaire. But, I usually tell to patients, I'll say, well, the fact that you believe that this may help you is actually a good prognostic sign that you will get better.
Absolutely. I always, again, I have a lot of patients that when I ask them, do you think, a couple of weeks with some physio or a couple of months with some physio with me is going to help you? And a lot of them turn around and say, well, I don't know. And a lot of physiotherapists are put off by that, but I actually see that as a positive. When I find a patient has, they've got no expectation, either positive or negative, I think that's quite a good starting position to go from. And a lot of patients do say, well, I'm not sure. I'm not quite sure. And I say, well, that's good, because it means that I can try and influence that expectation. What does make my heart sink is the patient that does come and see me because they've seen somebody else and I'm seeing them over a second or a third sort of consultation as an opinion. And they've got this very low expectation because they've been told they're going to need some other intervention like a surgery or something. And I find, well, now they've got that expectation in their head. That's very hard to change and turn around to get a positive outcome with my approach.
Indeed. And going back to, of course, we're trying to make decisions on the best available evidence that we have today. But of course, we have to be honest and say that the research is not perfect, nor will it ever be perfect, because there's always going to be limitations with data and synthesis to a degree. And so what are the limitations, Adam, of kind of the evidence that we know about the shoulder? And what are the big research questions that we need further answers or a further look at in regards to this?
Well, I think one of the huge limitations of the evidence space is that it's looking for a homogeneous answer to a very heterogeneous question, if that makes sense. So we're dealing with a heterogeneous population. So, shoulder pain doesn't just affect the athlete. Shoulder pain doesn't just affect the middle-aged housewife. Shoulder pain doesn't just affect the OAP. So we are dealing with, a heterogeneous group. And so we can't expect a homogeneous answer to come out from the evidence. And I think that's something, again, we just got to recognize that when you're dealing with something as complex and multifactorial as pain, there's never going to be one specific treatment for it. Now, I'm hugely biased because I like active treatments. I am very biased towards exercise interventions. And, when I look at the evidence, it is the strongest evidence that we have to show that it does work well for shoulder pain. I'm not going to say it works really well because the evidence power behind that isn't there. But when you compare it to our other modalities and our other interventions, exercise seems to be the way that the evidence is pointing as how to manage it. The big question around exercise interventions for shoulder pain is we've got absolutely no bloody idea how it works. And we've got absolutely no bloody idea about what's the best dosage, the best frequency, the best type of exercise. And to be honest, I don't think we're ever going to find that because of that same issue, because we are dealing with a homogenous treatment with a heterogeneous group population. So I think, again, it's a case of that we just need to recognize exercise is, I think, the best intervention for shoulder pain, for a lot of pain, if I'm being honest, back, not just shoulder pain, back pain, knee pain, hip pain, any pain. Exercise is the way, but it's just that sort of uncertainty around, we're not sure why it works or how it works. You know, sometimes it may be the process of the exercise that's more important than the outcome. Now, I take a lot of outcome readings with my patients. I like to look at handheld dynamometry, strength, range of movement. I sometimes use, my ultrasound to evaluate structure. And a lot of the time, I give somebody some exercises. I throw them some exercises to do for a couple of months, and I go and reevaluate those outcomes. And not one of those outcomes has changed one iota, but the patient goes, I feel great. This pain feels much better now. Thank you very much. And I'm looking, well, there's just as much weakness there. There's just exactly the same amount of range of movement. The structure looks exactly the same. Sometimes it can even look worse after the treatment, but they feel better and great afterwards. So I'm sitting there scratching my head going, how the hell did that treatment work then, if I've got no objective signs of any improvement? So again, I think that's something that us clinicians have to recognise in the research. I think we're going to come across a lot of this uncertainty as to why a treatment works, but it doesn't mean we stop using it. And again, and I see some people misinterpreting that, coming out and saying, well, if it doesn't show that it does anything, why are we carrying on using it? I'm saying, no, it's not that. It does show it works. We just don't know how. But we still got to keep looking. We always got to keep searching for the answers. We don't mean we have to give up either.
And, maybe the mechanism is just the fact that the patient thinks that it's working, and it's the placebo effect. I know that there's been lots of conversation with colleagues that I've had about just the power of the placebo effect and how it helps.
I always get a bit twitchy when the word placebo comes up, because I find I have a bit of a love-hate relationship with the placebo, because I recognise it's a thing and I recognise it affects everything we do. But I just have an issue when we are relying on placebo, when we are trying to just see if the placebo effect works, or we're just peddling placebos. I think we've got to be looking for more than placebo. And I would say, again, that although exercise has a lot of questions around it, it's more than a placebo. Not maybe for pain, but for other health-related conditions. So I think, the effects on the human system with exercise are not placebo. We see effects of exercise affecting people, but it's pain may be different.
Well, and there's a lot of research that has been coming out about just how the neuroplasticity of the brain can change with exercise and with pain. So, the mechanisms are not clear, and, realizing that, this question could be an entire podcast episode in itself. What do you think are the overall limitations of the research process and limitations of how research is being conducted or published?
Yeah, big question, big topic. Well, I'm not a researcher, but I am. I've done a little bit of clinical research myself. So, I find myself on the sort of one side of this sort of spectrum with dealing with research. But, I know that there are issues with research and the limitations. First and foremost, I think the biggest issue we have is the lack of funding. So the lack of sort of research money that's allocated to physiotherapy compared to other branches of medicine and healthcare is low. So I think a lot of the things remain, underfunded. Bias is another huge issue, and there's lots of biases that can affect the research. So not only just the author bias as well, but I think main one is publication bias. So I think a lot of physiotherapy research that's probably sitting in academics' drawers or on their hard drives that hasn't been published, showing probably a lot of things that we do have little to no effect. You tend to find it's getting a little bit better, but you tend to find a lot of the things that are published show that something works. I think reproduction studies are not often done enough. So again, just because we see one trial showing it works and all of a sudden now it's classed that we should start using this treatment, I think we've got to hold our horses a little bit until we get studies reproduced by, again, other independent researchers before we start jumping to conclusions. Adverse events in the research are very rarely reported as well, and I think that's an issue. Again, a lot of adverse events with sort of passive modalities are often, schmoozed over or completely not reported. Sometimes they're dismissed as just normal post-treatment soreness, and I'm like, well, that may be something else. Maybe, again, we need to be looking into that a bit more. We have very little research in physiotherapy that uses sham treatments or waiting list control groups sometimes. Again, we tend to rely on the very poor methodological model in our research of A versus A plus B. And a lot of the time, A plus B seems to show a better effect than just A. Well, yeah, whoop-de-doo, of course it would do. So I think, again, that needs to be looked at more. And then the other one, the last one, I think, with the limitations in research is just the lack of long-term follow-up. You know, a lot of our research has very short follow-up, and it tends to, again, just sort of give us a misrepresentation that something could appear to be working because there's a short-term change. But, you know, when you look at the long-term picture, the natural history of time and a lot of the conditions just naturally get better. And I think we're intervening too much too quickly with something that just has a high chance of getting better naturally. And again, that sometimes has implications that I think we're not quite fully aware of.
I think that's really important to really bring up those limitations, because I'm sure a lot of other clinicians are hearing as soon as he said this, well, what do I trust now? So I guess the follow-up to that is, what are the journals and resources that you have found most credible when it comes to physical therapy? Like if someone's looking for some credible sources to start kind of reinforcing their research bank.
All of them and none of them, I think, is the simplest way. I don't think I've come across, anything that I would say, I'll put my hand on my heart and say, I trust this implicitly all the time. So I don't trust any source as being credible or incredible. I would take it at face value and sort of analyze each paper. I mean, what's the most, valuable resource, I think, for physiotherapists when it comes to journals? Well, that's easy. I think Sci-Hub is the most valuable resource. I don't know whether I should be mentioning this, but, I have a big issue, again, with the evidence being hidden behind paywalls a lot of the time. I think that's pretty much fucked up, excuse my language, but I find that these journals out there are hiding the science and the knowledge behind paywalls. And knowledge and science, again, this is a bit of the socialist coming out, and it should be free to everybody. And I do have an issue with these journals hiding everything behind the paywalls. And thank God for Sci-Hub trying to correct that and trying to make it everything a bit more open access and easier to get hold of. Because these journals, when you look at the profits they're making, again, I'm getting on my high horse, are just outstanding. It's a screwed up system. The journal gets something for free. So an academic will give them a paper, sometimes free, sometimes it's the other way around. Sometimes the academic has to pay the journal to get the paper to be even peer reviewed to start off with. Then the journal then gets peer reviewers to work for free, and then they get that paper published. And then if you want to read that paper, you then have to pay the journal for something that they haven't even bloody done. So again, I find that a really screwed up system. So I think I am quite happy that there is something out there challenging it, something like Sci-Hub, and I urge all clinicians to use it regularly and freely. Screw these bloody journals making huge profits.
And for those listeners, you guys are kind of like, where can I find this? Just check the show notes. We'll have the link for it right there. And, I think, it's interesting because I know at least how it is in the US. I'm not sure specifically how it is internationally, but I forgot there's a certain amount of time frame between when evidence is created to when it's actually adopted into clinical practice. Was it like 15, 17 years? I've heard like 9 to 17 years from when something comes out. And
yeah, I think 17 years is the longest, yeah.
Yeah, it's like because then you're like, how much of it is this? How much is other stuff? I know there's people that are trying to be research translationalists. And I know there's a lot of work. At least there are some people that I know that are trying to try to get it easier to clinicians and patients, but it's a tough hurdle to overcome, that's for sure. So, Adam, what would you say overall, the big topics, of course, getting to more education realm, and we were talking on this earlier, what is the best way to address making sure that evidence-based practice is taught to a really quality level in all physio programs?
I wish I had the answer, Brandon. I don't. I think, simply put, is that the educators teaching it just need to be as up to date as they possibly can, and I think there needs to be some incentive and some sort of system in place that checks to make sure that they are, because again, I'm not going to name names or put any sort of accreditation onto any sort of association or society, but I see a lot of educators out there that are, or were, I should probably say, very well read back in the day, but then they get to a position and they just start to sit on their laurels. They get very happy and complacent where they are, a bit like a clinician does with their red flags, and they just tend to carry on teaching the same thing time and time again without questioning or challenging their thoughts or beliefs on a monthly, annual basis. So I think that's something that needs to be done, is that our educators, having their thinking, their teaching critiqued and reviewed. And I think on an annual basis is a good sort of balance. And that goes again with universities, and that goes with postgraduate courses, etc. Are they being, I think, peer reviewed by a body of peers that actually says this is correct, this is, as the evidence shows us currently at the moment, the sort of the best synthesis of what we are trying to promote.
So Adam, I know that there's been a big push for clinicians to utilize clinical practice guidelines because they're supposed to be best evidence, and they're supposed to have good outcomes as well. Let's gain some context. How were the clinical practice guidelines formulated, and what are the pros and cons of these guidelines?
Well, clinical practice guidelines are often formulated by a consensus of experts. So you get a panel of experts together, and they synthesize the evidence, and then they come up with these sort of best practice guidelines. And I think that's something where, we've got to be mindful of where things can go wrong. I mean, as the saying goes, never underestimate the power of people in large groups. So it can be very powerful, but there are negative associations. That consensus groups can be subject to biases. So you get similar thinking people all together in a room. They tend to come up with an idea, again, that's driven and led by bias. So I think the consensus group needs to be looked at for these clinical guidelines. Is who has come up with these guidelines? Are there people that are from the same society, same institution, same sort of training, same sort of backgrounds, or is there a sort of a wide spread of different ideas and opinions in that consensus group? So I think that sometimes can lead these guidelines to being a bit skewed into one direction over another, because again, maybe it's just down to bias of the group. And then the positive of the clinical guidelines is that I think they do help reduce the huge variance in treatment for a lot of things. So one of the biggest issues we have with physio is the difference and variance in how physios treat the same conditions and issues they see the world over. And I think guidelines very much do help reduce that to a certain degree. So I think they say there are some positives and some negatives. The positives reducing variance, the negatives is that they can be biased depending on who's come up with them.
I think that's really good to know. And I know earlier when you had said that wishing that a lot of educators and faculty members would actually kind of continue to stay up to date with the most evidence. But I'm going to ask if you could say another thing perhaps to all physio educators and program directors, what would you say?
I think the main one is listen to clinicians more. I think that is something that they need to be listening to those that are working day in and day out at the cold face and dealing with people in pain, and listening to their experiences and their sort of narrative around how the evidence sometimes confuses the hell out of them about how to manage, how to proceed, and also the challenges that they face, and try to take these things on board when they are promoting of a certain technique or an idea of how we should be managing as clinicians. So I think they just need to recognise that there is difficulties in working in a clinical environment compared to an academic environment. I'm not saying one's better than the other, it's just different.
Along those lines, if you could say one thing to the Physiotherapy Curriculum Accreditation Board in the UK, what would you say to them?
Yeah, exactly the same thing. Please listen to clinicians more, get their perspectives and their narratives and their frustrations about, their day-to-day practice in dealing with pain. And I think, that they'll be surprised at probably what comes back, the challenges that they face, the underfunding, the lack of time, the lack of resources that they have, and trying to work in these constraints in an evidence-based, clinical environment is very challenging. It's very hard work. And so when people are, spouting and espousing that we need to be doing X, Y, and Z with everybody we see, I'm like, well, you try and do that with Mrs. Meakins when you've got 5.5 minutes left of your evaluation to do. So I just think, again, it's just needing these societies and accreditation boards just to recognise the challenges of clinical day-to-day practice better.
Absolutely. And I know that they've talked a lot here in the US about really trying to come together to join the clinical world, the academic world, and really cohesively work together, because there are constraints on both ends. And I think it really takes a school and a clinical practice / clinician to really have an open mind to realizing there's limitations on both sides, and we have to start coming together on this. Otherwise, it's just not going to change.
Absolutely.
So kind of realizing, so let's play a hypothetical situation here. So let's pretend that there are absolutely no accreditation requirements, no licensing exam, nothing like that for physio school. If you could create a physio school or a curriculum and a pathway, and the sky's the limit without any barriers or crap, what would your ideal program look like?
Well, there would be some accreditation and evaluation in it. That's the first thing. So I think we do need policing. So I wouldn't just let anything, go without saying that there needs to be some, level of competencies still out there. So I don't think I'd be quite happy just to have physios out there without any of that going on in the background. But if I could design my own ideal sort of physiotherapy training program, well, again, I think I'm biased, obviously, so take that into consideration. But for me, I think if I look back, I think what my training lacked, and I think a lot of sort of undergrad and training still lacks, is more time spent on the communication skills. That term that's often used, which I bloody hate, is soft skills. They're not soft skills at all. They're bloody hard skills. But learning things, like interviewing skills, motivational interviewing, counselling skills, empathetic listening skills, and then having a clinician better armed and equipped to deal with how to challenge negative beliefs and fears and other behavioural problems as well. That's the bit that I lacked when I came out of physiotherapy school. I had patients that had very negative beliefs and understandings of what their problems were or how they could get better. And I felt, lost. I didn't know how to help or manage them. I had to go on postgraduate training courses to learn how to deal with these things. So I think that's something that I would definitely emphasize more in my ideal physiotherapy training program. And then another area, again, because I'm hugely biased, is more on exercise physiology and prescription. Again, going back to my strength and conditioning sort of background, I was amazed when I went into physiotherapy school. I was expecting to learn more about exercise, programming, periodization, biomechanical aspects on it. But I was just absolutely flabbergasted as to how poor physiotherapists are trained on exercise prescription and physiology. So my ideal physiotherapy school would have a lot more time spent on how to dose adequately, because again, I think that's a huge issue, is the dosage of exercise that physiotherapists give are often unfortunately underdosed, which is why I think we see a lot of the research showing limited effects of exercises. I think it's not dosed adequately because there is that fear of damage, harm, pain, etc. So again, going back to that other area, the third and final area is better education on pain science, not to give physiotherapists the confidence not to fear pain, because a lot of physios are coming out of schools not fully understanding pain, and they do fear it. When you don't know something, you tend to fear it. But once you've learned more around it, I think the fear levels go down and you're not so worried about creating pain, causing pain in patients, which we sometimes have to do when we're trying to get them to move forward and get a successful outcome. So yeah, my ideal physio school would encourage those three things.
Speaking of teaching, you have a course that's coming up in Washington, D.C. on September 22nd and 23rd of this year.
Yep.
Could you tell our listeners about what you'll be covering in this course?
So this is a joint course with me and my mate, Erik, Meira, over from Portland in Oregon. And I suppose the first thing that you'll probably experience if you come to the course is you'll hear me and Erik argue a lot about the role and the value of exercise, because we do tend to have quite different standpoints. So again, if you've read any of Erik's work, you'll probably realize he has a different view on exercise and I have a different view on it as well. So there's a little bit of to and fro and a bit of banter from that. I think the main thing that you'll get if you come to see me and Erik talk is you'll come away hopefully with more confidence in the uncertainty of why things hurt and how to manage people with pain and problems. So I think it's trying to give clinicians that confidence in the uncertainty. And then I think the last thing that me and Erik are big on is just trying to get clinicians to know what is the important stuff to focus on and what's the fluff and detritus around the edges that isn't so important. So basically simplifying your sort of assessments, your clinical reasoning and your practice by trying to remove a lot of unnecessary gumph that goes around it. And then finally, I think Erik and myself have got a unique education style, so we try to make our courses as fun and interactive and enjoyable as possible. So we're big believers of the term edutainment as well. So it won't be like any other sort of standard courses I think a lot of people have been on. That's the feedback we tend to get anyway.
Very good, because yeah, it seems like relevance, fun, simplicity, and entertainment seem to be the big 4 takeaways there.
Yeah, they're the main ones.
Yeah. So guys, if you're kind of want to check it out a little bit, because I'm actually going to the course as well. It's going to be in DC at Meira University. And if you're not sure, check the link in the show notes because it'll take you right to it. And I know there is an early bird special for the time being. Is that correct, Adam?
Yeah, that's still going on. I think it goes until a month before the course goes live. So I think it's until, end of August.
Perfect. So I know you've answered a lot of questions when it comes to how we can improve healthcare education and physio education. Because our last question that we normally tend to ask every single guest is this following question. If you could change one aspect of healthcare education, whether that be physiotherapy or other healthcare provider related, which aspect would you change and how would you change it? And since you've said a few of them earlier, if you want to further reiterate a point, that's fine, or bring a new point that perhaps we haven't brought into fruition yet.
I think I'll go back to one of the points I made and just probably re-emphasize it. I think the biggest aspect of healthcare that I would like to change is the financial reimbursement and reward scheme, because I think that is driving healthcare in the wrong direction. Again, I often say to a lot of clinicians, could you imagine how your practice would change if you got reimbursed and you got bonuses for getting people that come to see you back to work or doing tasks that they can't do quicker, rather than obviously just getting paid per session? Do you think your practice and your thinking would change? And I think it would change hugely. And again, do you think if you got rewarded for not treating financially and turning patients away and say, look, no, this has got a good, favourable, natural history. There's nothing here for you to worry about. I'm going to discharge you and say to you, that's fine, and you can carry on. Maybe keep it open-ended for you to come back if you've got any concerns. And then you got the clinician to be rewarded for that. I mean, there are negatives to that because sometimes, again, it can be overly done and people could be sending people away without going through proper evaluations. But I think, again, if the financial reimbursement scheme changed slightly, I think we'll see healthcare change hugely.
Well, this has been a very enlightening discussion, Adam, and we appreciate the time that you've taken out of your day to talk with us today. People have questions for you afterwards, where do people find you online and on social media if they want to reach out to you?
Yeah, well, anywhere on social media. So I'm on Insta, Google, Face, Twitter, or whatever you want to call it nowadays. So I'm on most sort of platforms. So I'm on Twitter. My handle there is @Adam Meakins, but you can also probably find me under the Sports Physio. I'm on Facebook as well, using my name as well as the Sports Physio as well. Got 2 pages there. Instagram, again, @Adam Meakins, you can find me. And then I've got my website, which is also www.thesports.physio, where I do my blogs and my...
Perfect. And for our listeners maybe curious, those are all in the show notes for you. So go feel free to check them out. And I also put some of Adam's previous podcast interviews there if you want to take a listen as well. Well, Adam, first and foremost, thank you so much for the time, dedication to the profession, doing what you're doing. And it's really been an honor.
Hey, thanks for inviting me on. And I've enjoyed it. Thanks for the chat.
Hey, everybody. Thank you for listening to the Healthcare Education Transformation Podcast, as we greatly appreciate your support to help us advance healthcare education. We are very happy to announce that we have created a new tool to help develop clinicians into better experts. With that being said, we have created the HET Light tool, which LIGHT stands for Learning Integrated Towards Expertise. And what we've done is we've taken our first year's worth of episodes with experts in the fields of healthcare and education, and we've taken one golden nugget or theory on expertise and presented it to you in a very easily consumable format so that people can take one lesson or nugget per week and map out and plan how to incorporate it into your clinical and educational practices. And by the end of the year, we think you'll be pleasantly surprised at how far you've progressed towards becoming an expert. To find out more, please check it out at pteducator.com/HET, which is also available in our show notes. Thank you again all for your continued support. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter @HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.